And we're live. Setting up our links so people can see us, because, you know, we all love to be seen. You know, it's the histrionics in all of us. You know how it works. Oh, wait, is that me? Ouch. Just letting people know we are keeping this. This does say we're going to be deleting it. We're not. This is actually going to be the... as I delete stuff. This is actually going to be the adrenal video. So we will not be deleting this. Like the video says, I will be editing this afterwards. So, why don't we start this up, shall we? And links are set. So, we're starting with the adrenal glands. Again, we've all heard these. We love them. So, how many adrenal glands do we have?
Two.
Adrenal glands.
You have
How many
two, but they can be considered as two separate glands.
Correct.
So,
in all
because
technicalities.
there's a middle and a cortex, the medulla and the cortex.
There's an inner and outer piece. What types of tissues are these made of?
The middle is neural, and the outer is endocrine.
Yep. So if you want to think about it, look at our lovely, lovely picture here. You can kind of think about our systems in this way. You know, we've got our inside when we're talking about our medulla, and then we've got our outside, which is our adrenal cortex. Each one of them, we have to start thinking about things like fight or flight, our stress responses. But we're going to talk about each one of these. You know, like medulla. Those release catecholamines, right? Those release our epi-norepi. Whereas our cortex, our adrenal cortex, likes to release our corticosteroids. Now, the cortex is what we're going to start with, just an ideas of functioning. So when we're talking about function, we know that the cortex, we know about the general idea of this, it's vital for life. We need to think about salt, sugar, and sex when we're talking about this. Uh-oh, sex, 18 plus, we can say it all we want. So, what are the three things that are produced here at the cortex?
Cortisol.
Cortisol, which is a glucocorticoid.
Aldosterone.
Aldosterone, which is our mineralocorticoid.
Androgen.
Androgen, our sex hormone. Male sex hormone, right? Which is still interesting to think about what happens if males get too much of it. So cortisol, sugar, aldosterone, salt, androgen, sex. What do glucocorticoids do to our blood glucose?
Increases.
Increases our blood glucose, regulates our metabolism. Also is critical for our physiologic stress response. What does aldosterone do for our sodium balance?
Increases.
Yeah, it can actually increase it, depending on what's going on, right? It holds on to it. Androgen is necessary for which gender's growth and development?
Both.
Both. The sexual activity it drives is for female, but it's necessary for both genders' growth and development. So, just to throw a little general classification out there, throw back to aldosterone, right? We're thinking of our mineralocorticoids. We know aldosterone grabs onto salt, right? What electrolyte is has an inverse relationship to sodium?
Potassium.
Potassium.
So what is a side effect of an ACE inhibitor? I'm going to go from A to Q on that one.
It increases the potassium.
Yep. Remember, ACE inhibitors drop your aldosterone, thereby dropping your sodium, thereby dropping your blood pressure, thereby increasing your potassium. Casey!
Hey, what's up, y'all?
Yo, just so you know, we are recording. We are
Okay,
doing
cool.
our adrenals, so basic rules are on, just so you know. We're doing our adrenals. We're doing gland recording, so one recording for... All right. So our side effects, hyperkalemia related to peeing out that sodium. So, what axis are we talking about when we're talking about the adrenal glands?
The hypothalamus, pituitary, adrenal.
Yes. Hypothalamus releases what hormone to target the pituitary gland?
PRH.
Corticotropin releasing hormone, right? Of course, then we also have our ACTH, which in turn will target our adrenal gland, and that causes our glucocorticosteroid or cortisol release. If our glucocorticosteroids begin to raise, what hormones begin to decrease?
Insulin?
CRH and ACTH. Remember, negative feedback loop. There we go. Come back here. Come back. There we go. There it is. So, hypothalamus releases CRH. Tells the anterior pituitary to release the ACTH. We've got our adrenal cortex, sees that. We're like, oh, here's cortisol. Cortisol levels go up. Our CRH goes down. Our ACTH goes down because cortisol levels have gone up. Here's your negative feedback. I'll leave these up for a little bit while we're talking. Probably prettier than my face right now. There we go. All right. So that's your general idea for that. Now we're going to go inside. We got to go to the jelly donut part, to the jelly. To the medulla. In the center, we've got the adrenal medulla. Secretes the catecholamines, part of the autonomic nervous system. Transmits your epi-norepi. Deals with preganglionic sympathetic nerves, which are stimulated. This stimulates the adrenal medulla to release epinephrine, norepinephrine. Causes your fight or flight response. So, you've got your epi-norepi, which will cause an inducing of the release of free fatty acids, increases your basal metabolic rate, and elevates your blood glucose levels. So, down here, we've got lots of things. Cortisol increases your blood sugar. Epi-norepi increases your blood sugar. So your adrenals like to increase your blood sugar. So, now let's go into our pheochromocytoma. Pheochromocytoma is your adrenal medulla disorder. What is pheochromocytoma? What is it discussing?
A tumor on the adrenals?
Yeah, catecholamine secreting tumor in the cells of the adrenal medulla, to be specific. So if it's in medulla, what's it secreting specifically?
Epi and norepi?
Epi-norepi, right? So, Our symptoms are based on that idea. Now, somebody gave us a great thing to think about this. And if you don't like it, don't listen to it. But we'll go through it in just a second. So symptoms, sympathetic overactivity increases your catecholamines. You've got your 5 H's. Hypertension, headache, hypertension, headache, there you go. Hyperhidrosis, hypermetabolism, hyperglycemia. You're up, so palpitations, tachycardia, anxiety, tremors. You've got elevated levels of catecholamines. That one's not bad. What's the name of the test that we check for this?
Vanilla mandelic acid.
Yes, vanilla mandelic. What foods interact with this?
Vanilla.
Chocolate, vanilla, bananas, caffeine.
Yes, can't have any of those chocolate milkshakes, right? If it's a tumor, how do we detect it?
CT, MRI, Sam.
Yep. So this person's going to be in the ICU. That's a push meds, right? Pheochromocytoma has what meds? Phentolamine, phenoxybenzamine, fenphens, not really fenphen, but phentolamine, phenoxybenzamine, alpha adrenergic blocking agent. Now, phentolamine is the first one you give. Alpha adrenergic blocking agent. If it's a blocking agent, what do you think it's going to do to your blood pressure?
Lower.
Blocking agent. Yeah, it's going to lower it. It's going to induce hypotension. So if you've been hypertensive and you induce hypotension, what's the side effect?
You're going to send them into shock?
Yeah. You're looking at MI issues. You can, of course, go into shock, but you're looking at big MI issues, cerebrovascular spasms. Then you have, for your longer lasting, you've got your phentolamine, shorter word, quick drug. For longer lasting, you've got your longer name, phenoxybenzamine, long acting alpha blocker. Maintain. Now, we have surgical management. If it's a tumor, what are we going to do?
Take it out.
Take it out. What's it called if we're removing the adrenal?
Adrenalectomy.
Holy crap, that was hard. Must watch, of course, if everything's up and we take it out, just like before, just like reducing it. If we watch it, we start taking things out, we have to watch for shock. Profound shock can develop. So what should we make sure we do? What do we have to check?
Their vitals, their blood pressure.
Got to watch that. Ow. And we need to watch that. Remember that hypertension can last anywhere from a day to 2 days. So we'll watch that. Hemorrhage can still occur, just like usual, any surgery. Monitor the vitals and response to medications. If it drops too quickly, it can cause poor perfusion to the vitals. Again, MI issues can occur, other issues can occur. Shock, monitor, ECG, fluid electrolytes, and blood glucose. Now, as we were saying earlier, we got Pheo and his 5 Ho's. Pheo and his 5 Ho's, hyper, headache, hyper. He's allergic to vanilla. Can't have those. Vanilla. He's got his friend Mandela, Vanilla Mandela. So he can't have vanilla, can't have chocolate, can't have caffeine, can't have vanilla. On that one. We kind of like that. He's in his he's in the ICU because his 5 Ho's beat him up. The medications, again, that's what we used on those ones. Pheochromocytoma, Phe is what we looked at those. The shorter name is what you give first, because the shorter response, but quicker. And then the longer name is a longer acting, so something you use for it, long acting. So that's your idea for pheochromocytoma. Now we get to the thing that causes everything to go away. or your adrenal cortical insufficiency, also known as what?
Addison's.
Addison's. Remember, if we see Addison's disease or something like that, or something that describes it, we have to add it back. What should be there is not. And of course, we have inverse relations. So, sodium is not there. Water is not there. So, potassium is there. So, adrenal cortex function is inadequate to meet the patient's need of cortical hormones, usually related to autoimmune or idiopathic atrophy of the gland. Idiot, we don't know why. So, you've got your adrenal insufficiency of your sugar, salt, and sex. Pathologically speaking, it's an autoimmune issue, or a lack of your ACTH from the pituitary. It's not functioning very well. Decreases level of your mineralocorticoids, glucocorticoids, and androgens. So let's start with your first one, salt. What is that related to?
Aldosterone.
Aldosterone, exactly. So we have issues with fluids, we have issues with electrolytes. So what's going to happen to our salt if we have low aldosterone?
Decreased salt.
Decreased salt levels, right? It's going out. We have higher potassium levels because of that. What happens to our water levels?
Increased excretion with the sodium.
Oh, there it goes. What does that put you at risk for?
Hypovolemic.
Can you leave that? Depletion, dehydration, hypovolemic issues. What's your blood pressure going to be like?
Down.
Down.
Hypertension. What's your cardiac output like if you don't have fluids?
Decrease.
I don't care how hard you're if you don't have the fluids to do it. Remember, like our Grinch thing. So what's your cardiac output like if you don't have fluids?
Shrink.
We said it down, right? What's our heart going to be like if it's not working very hard?
Small.
Yeah, it's getting smaller. And again, as our heart gets smaller, it works less. It doesn't need as much. What's going to happen is it gets weaker and weaker and weaker. What's the end point?
Death.
Yeah, it just stops. Shock, death, and of course we get more and more potassium. And of course, as potassium goes up, we get closer and closer to that cardiac arrest. So we get less and less fluid, it stops working as much, and then of course we get more and more potassium leading to arrest. Just a whole bunch of issues. Lots of issues with that. Now, that's our salt. That one's an easier one. Let's think about our glucocorticoids. Cortisol, our sugar. So, we have lots of metabolic issues when we have sugar issues. If we are low on our cortisol, what's our blood sugar going to be like?
Down.
Yeah, okay, I could go into hypoglycemia issues. Liver glycogen deficiencies as well. What's the patient going to look like?
Full, clammy, diaphoretic. Weak.
Weak, anorexic, weight loss, nausea, vomiting, emotional disturbance. We're low on a steroid, right? How is their stress response?
Decreased stress response.
Absolutely no stress response, right? So let's say we know somebody who's got this, and we're preparing them for surgery. Let's say they have to be MPO for 2 hours, for 12 hours for surgery. What do we need to make sure that they have an increased level of before surgery?
What are you wanting to prevent?
The steroids. We need to make sure their steroids are up higher. They have a deficiency in steroids. So that means they have a deficiency in stress response. So remember, we talked about this today. If they have any of these issues, they automatically have an issue with stress. And they're going to be on medications for this. And they're going to be dealing with these stress. If we're preparing for a very stressful event, like a surgery, we need to have those medications altered so they have an increase in steroids to handle the new stressful thing about to happen.
Okay.
Otherwise, they're going to have a higher risk for infection, sickness, falling into an Addisonian crisis. We don't want shock. We don't want an Addisonian crisis. So cortisol deficiency, let's see, you have your ACTH. If you have ACTH being secreted, let me show this again. So we have ACTH, and it's being secreted. It's going higher than normal, but we're still not getting cortisol. Where's the issue?
Adrenal.
The adrenal cortex. So what is it? Primary, secondary, or tertiary?
Primary.
Primary, right? What's their skin going to be like if it's a primary adrenal cortex issue?
Tan. Increased pigmentation.
Mm-hmm. Mostly at your, creases, etc., right? ACTH kind of attaches those melanocytes. All right. So you think about the pressure points over your joint, skin creases, palmar creases, depressions, joints, knees, knee pressure. You get a bronze look, right? You got JFK, right? All right. So we've gone down. We have somebody with this. They can keep going. What's the crisis stage? What's the all the way down there? So we have we have a no line. So when we talked about, when we talked on the other video, when we talked about our thyroid, we had hyperthyroid, and then we had thyroid storm. Down here, going down, we had going down, and now we're going all the way down. What's down here?
The Addisonian crisis.
Yeah, that one's an easy one. So Addisonian crisis, we don't want this. Remember, we talked about preventing this before that surgery by giving extra steroids. What causes an Addisonian crisis?
Stress, infection, trauma, hemorrhage. Something happens suddenly.
Mm-hmm. A sudden, these things all there, but all these would cause a sudden sharp decrease in hormones. So insufficient cortical hormones, dehydration from prep. So your insufficient cortical hormones and sharp decrease from that. So we didn't prepare them for it, or they weren't ready for it. So let's see. Hemorrhage, dehydration, diagnostics, sudden withdrawal of the corticosteroids. So they also just could be going, and then, especially if you're talking pediatrics, if mom and dad aren't listening and they decide to take them off the steroid, and they just drop down when dealing with stress. What's the blood pressure like in an Addisonian crisis?
Down.
Hypotensive, right? So if everything's hypotensive, we're looking at cyanosis, circulatory shock, pallor, apprehensive, rapid, weak, pulse, rapid respirations, low blood pressure. So if everything's down, what kind of IV fluid do you want to give them?
D5, normal saline.
Glucose and electrolytes, sodium. We're missing steroids. What do we want to give them?
You want to give them some?
Give them steroids. Remember, this is your emergent. Remember, we're all the way down here. In the emergence, give them what they're missing. Treat it. We are all the way down. Bring the IV fluids in. Give them their sugar. Give them their salt. That's what we're missing, right? Give them their steroids. And bring that blood pressure back up. How do we bring the blood pressure back up?
Those fluids are going to help.
The fluids will help, but how can we force it?
Vasopressor.
Vasopressor. And the names of the drugs we use for vasopressor?
Desmopressin.
Desmopressin.
And Pitressin.
Or DDAVP. I like DDAVP because if you look at it, it says Davy. Okay. All right. So, remember, this is sudden. An Addisonian crisis is sudden, so that's a big issue. We do not want them to get here. We're trying to prevent this crisis. What is the, let's see, so when we're dealing with adrenal insufficiencies, we're out of the crisis stage, just getting down to the general Addisonians. So, when we're assessing it, we know there's not a single specific lab we can do because it's just pretty much everything's going down. There's not a specific lab. We need several, we need several labs to actually figure it out. So, what are some labs we can pull to figure it out?
Well, you're gonna check the steroid levels, cortisol levels.
Yeah, I mean, if it's, let's think about what we have an issue with and pull those labs. So, cortisol, early morning. What else? Serum cortisol.
Your electrolytes, sodium, potassium.
Sodium, potassium.
ACT.
What are we going to pull from the blood?
Glucose.
Glucose. One more thing. Oh, two more things from the blood.
White blood
Already
cells.
said sodium, potassium. White blood cells, yeah. And plasma. ACTH. Remember, I'll show you the chart we have.
ACTH.
Yeah. If we're here, if this is going up and our cortisol is still low, we know it's a primary issue. Primary Addisonian crisis or primary Addisonians. We can pull it and find that out, right? All right. Medical management. We know about dropping. It's about dropping, it's about shock. Let's stop the shock. We've already said this 100 times. We're going down, stop going down. Stop the shock from coming on. Give them fluids. Monitor their vitals. What position will we want them in?
Recumbent.
What's recumbent?
It's laying down flat with your legs elevated up.
It's kind of like birth position.
Yeah, basically.
Yep. So, yeah. Recumbent, legs elevated. Kind of gets everything back to the core, right? And again, they're low on things. Let's get their steroids back. What medication would we want to give them? We said steroids, right? So which one do we give?
Hydrocortisone.
Hydrocortisone, Solu-Cortef, Solu-Medrol. So, we're low on everything. What's going to happen to our blood sugar when we give this?
We'll go up.
Yeah, that's the point of this thing. It's one of the things that happens, right? It's counter-regulatory to insulin. So, whoop, bring it back up. So, steroids. We're giving it to these patients. Remember, when we take them off of it, we need to taper it. What do we need to give an adjunct to this because of its GI issues?
Didn't you say like PPI or something the other day?
PPIs and H2 receptor antagonists to help with those GI receptors, help with those GI issues, because it is tough on the GI. What meds do we not want to give with this?
Aspirin or NSAIDs.
NSAIDs, aspirin, ibuprofen.
Or Zantac stuff, right?
Well,
Or
anything?
Zantac for some reason.
Is Zantac an NSAID? I don't know that.
No, it's a
It's like to give a PPI, the Protonics or Zantac for the stomach. Because of the
GI.
the GI sensitivity from the steroids.
Okay.
Yeah, they say they get it all the time. Yep.
Okay.
So, yeah, that's what they just had it down. Oh, yeah, I have it down there as giving it. So, let's see. We have to educate them about steroids. What are some things we need to educate them on? Parents or patients in general.
Don't stop them suddenly. Take them as directed. Don't increase or decrease just because they feel like it.
Mm-hmm. What else? What does it mask?
Infection.
Mm-hmm. So, cortisol, steroids, slow or stop our body's inflammatory response system. It's a steroid. It helps us handle stress, right? So if we have it out there too much, it kind of handles it for us by not letting us do anything about it. So all of a sudden our temperature doesn't rise, nothing's really there, we don't really get to see anything. So we need to tell them that at the first sign of a slight temperature raise, they need to call the doctor and start seeing any signs of infection. We need to explain to them the signs of infection, any slight sign they need to call, especially a temperature raise.
David,
Hmm?
you may not see a fever.
Right, that's the thing. If you happen to see a fever, call the doctor. But that's what I'm saying, like these can stop that too.
Okay, I was confused.
Yeah, I'm sorry. Like if you happen to see any signs of infection, call the doctor.
Right, because you may not have a fever.
Mm-hmm.
Okay.
All right, so that is our Addisonians. Let's do Cushing's, much shorter. What do these guys look like?
Central obesity, the hump on their back.
Oh, hold on. I'm sorry. There was one more thing on Addisons, the nursing management. We should probably do that. Nursing management, we've already talked about most of this. Monitor your fluid electrolytes in balance. Drop their stress. What's the room need to be like?
Relaxing.
Turn the lights off or dim them. Quiet, calm.
Should they be in a facility with a manic patient next to them?
No.
Yeah. Watch for signs of the Addisonian crisis. Watch weight changes, muscle weakness, fatigue should be assessed. If they're getting stressed out, what should they do with their diet?
You need to increase their sodium,
Mm-hmm.
decrease the potassium, decrease their urine output because that'd be excretion, and make sure they stabilize their blood sugar.
As best they can, right? Now, that stress includes, hot weather, sickness, and make sure they realize what they've got. So, they need to realize what they have as well. Like any disease that's chronic, they have to master it themselves. Because if they realize they're having a surgery, they may have to realize, hey, do I need to get my steroids up before I get this surgery because of the stress response that my Addisonians could, because I have Addisonians disease, will do? Okay, now we're good. Now let's go back. As you were saying for Cushing's, explain again. Sorry, Casey.
Central obesity, the hump on the back of their neck, like upper back, thin extremities, stretch marks on their stomach area. Women will have like facial hair, how do you say it? Hysterism?
Hirsutism.
Decreased libido, depression, just very frail.
I don't know what a stretch mark is.
Right.
Striae.
Oh, okay, that's better. What's their blood sugar like?
High.
Yeah, their blood sugar's high. What's you already said they have a decreased libido, right? What's going?
Yeah.
Why do they have thin extremities?
Muscle wasting.
Yeah, protein breakdown.
Now, we have our central obesity, buffalo hump, heavy trunk. We've already you just said all of this stuff. Now, this is an excess adrenal cortical activity, so lots of stuff is being made, right? What specifically is being overmade in Cushing's?
Glucocorticoids.
Which one?
Sugar.
Cortisol, right?
Okay.
What is the common cause of this?
Chronic use of corticosteroid medications.
Steroids. So, normally you're going to see persistent hyperglycemia, which puts them at risk for what later on down the road?
Type 2 diabetes.
Okay. Protein tissue wasting, catabolic effects, weakness, especially in the extremities. We already said that one. Protein loss in the bones leads to osteoporosis, bone, back pain. Potassium and calcium depletion. Sodium and water retention, right? Switch that. Abnormal fat distribution. There's your buffalo hump. Increased susceptibility to infection. Lower resistance to stress. Again. Virilism. What happens in women?
Facial hair.
What's a facial hair?
Facial hair?
What's that?
Hysterism.
Oh, hirsutism. Oh, I got that.
Hirsutism.
Ah,
Say it again.
Hirsutism. It's the werewolf disease. Extreme hirsutism is werewolf disease. But go ahead. Or it's actually hyperhirsutism.
so what's
Hirsutism. Hirsutism. So yeah, excessive androgen gives women hirsutism. What else?
Gives guys boobs.
Moobs. I can use that, but what else? Organocomastia, right?
impotent?
Impotence in males. Back to females. What about their time of the month?
No. Either too often or not enough. Or none.
Yeah. So amenorrhea, menorrhagia. You've got your mental changes as well, right? So if I need to diagnose this, what's my big diagnostic test? There are others, but the big diagnostic test is what? Remember, our body is lazy, this fat guy, because of this. It's not necessarily, but I'm still saying this for generalization terms. Big person, lazy body. Our bodies are lazy. They don't like to do work if they don't have to. So what test do we do for this?
The overnight dexamethasone suppression test.
Yes. Why would we give more steroids if we have too many steroids?
Because it has to do with in the morning when you check that level, steroid level, it will tell you
That
issue.
Yes, but
If it's functioning properly or where it's breaking down at in that system.
that 1 and 1 is 8. You missed like 3 steps.
Yeah.
Why am I giving a steroid if I already have too many steroids?
If suppression occurs, it
Don't
says.
you dare read that to me.
Well, I tried to tell you out of my head. I know what I'm saying. Someone else take a turn. I quit.
Your body, like you said, your body is lazy. So for giving the steroid, your body will stop decreasing the steroid. That's why, like, you can't just abruptly take someone's off steroids because their body needs to adjust and remake steroids. Does that make sense?
Yes.
Once again, I'll present this. Maybe we should, I don't know if I've said this, you should probably draw this on the test. So, lots and lots of cortisol, right? Boom, 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 lots and lots and lots and lots and lots and lots of cortisol. It's going out. We don't know exactly why. We can look it up and try and figure it out, but this is one of the reasons we're diagnosing it. So, we're like, okay, we're going to give some dexamethasone, which is another steroid. If we give it, and this system is working correctly, we put it in here. Our hypothalamus will see a steroid. Our anterior pituitary will see it.
So you should have suppression. And
These should then be suppressed, right? Our cortisol levels should then drop in the morning, shouldn't they?
And then if they're still up, then obviously the feedback didn't work and there's an issue in that loop. Because it's still producing? Is that what you're saying?
Yeah, see, if the cortisol suppression occurs, it indicates the hypothalamic pituitary axis is functioning properly. So that kind of gives you an idea of what we're doing that for. Now, if those levels don't decrease, there could be an issue at that adrenal cortex. There could be an issue at the pituitary. There could be an issue at the hypothalamus. That just kind of tells us, or there could be an actual major stressor in our body. So, I mean, if this dexamethasone actually suppression test is actually working, let me say this correctly. If the dexamethasone test shows us a positive result, meaning cortisol drops, this is working. This axis is working. So something's stressing us. If that cortisol level doesn't drop, then we know there's an issue in this axis. And say it correctly, sorry. All right. A few other tests include serum sodium, potassium, blood glucose, eosinophils. So these are steroids. So we see a decrease in eosinophils. Never let monkeys eat bananas. 24-hour urine done for free cortisol. Nighttime salivary cortisol test. All right. If we have too much cortisol, what's our goal going to be?
To reduce it.
Might have been that wasn't too bad. If it's a tumor,
Remove it.
we're going to probably radiate it. But if it's a tumor related to pituitary tumor, remove it. So, Cushing's guys get meds. Cushing's guys are big. Cushing's guy like Big Mac. MK. Mitotane. Aminoglutamide. Ketoconazole. Ketoconazole special, especially with type 2 diabetics, because they can't take it with another classification of drug. What is it?
I don't remember.
The Actos, what class was that?
Oh, your Actos. Yes. That's your zones, right?
Yeah.
Glitzaone.
Oh, and then there's...
The thiazidine.
Yes, that's what I was thinking.
Well, it's the same thing.
Okay.
So, we have got the side effects there. And so these are things that suppress cortisol production, alters peripheral metabolism of cortisol, decreases plasma urine cortisol levels, so kind of pushes it out. So, side effects, nausea, vomiting, GI bleeds, get it out, get it out, get it out. Depression, vertigo, skin rash, diplopia, get it out, get it out. Now, if the Cushing's is actually from taking too many corticosteroids, we can taper off the meds, see if it helps. But if the issue comes back, that's the reason the meds are being taken for, and they have to stay on them for life, what do we have to do to support them?
Image.
Yeah, body image is a big issue for them, right? We have to support them mentally, help them realize what's going on. Now, these patients are larger. We need to monitor them for risk for injury. They can have skin breakdown, mental changes, risk for infection, woof, 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 woof. Who's woofing?
Oh, sorry, that's my dogs. I'll mute my thing.
Oh, that's right. It's because we're recording.
I'll just do that.
Support your body image changes, like we said. Monitor for signs of adrenal insufficiency. Because anything, if we treat it, we can treat it too well, right? And monitor for neural changes because of sodium. The last thing is our primary hyperaldosteronism. If we've got hyperaldosteronism, what is aldosterone attached to?
The RAS?
Well, that's part of RAS, but what is it attached to? Sodium.
Okay.
So if you have primary, you know it's part of your adrenals, right? Your cortex. So you've got primary hyperaldosteronism. Too much salt. Potassium's low. Lots of water. That's pretty much what it is. So what meds are we going to give? We got to get rid of that fluid, right? So we're going to give a diuretic?
Potassium sparing.
Yes. We've got to give potassium sparing because we're low on that. So we got to give spironolactone or aldactone to get rid of it. The goal is to reverse the hypertension from all that fluid, correct your levels of potassium, resolve the hypertension. So that's your general idea for these. Now, we just went through all the adrenals. Those were pretty fun. Those were pretty interesting. I'm going to stop the recording now because we're going to be making a different set, one big thing for questions. So this was your aldosterone, et cetera, for your adrenals. Hope you had fun with them. Yada, yada.